Thank you everyone for joining us today. I'm Heather Gatney and I'm the coordinator of the CVFS webinar series. Our host today is Emma Banchoff, PhD student in sociology at the University of Michigan. Using CVFS data, the research Emma will present today explores the intergenerational link between mental disorders and family formation, with a focus on mothers' depression and daughters' fertility behavior. There will be a Q&A session after the presentation. We ask that you remain muted until then. During the Q&A, you may unmute and ask your question, or you can submit a question at any time today using the chat feature. We'd also like to remind you that this webinar is being recorded. If you have any objections, you may disconnect at this point. A recording of the webinar and the slides will soon be available on the CVFS website. So that's all yours, Emma.
Great. Thank you so much, Heather. As Heather said, my name is Emma Banchoff. I am a second year PhD student in the sociology department here, and I've been working with CVFS data as part of my Population Studies Center traineeship since I got here in the fall of 2020. So I'm excited to talk about the work that I've been working on with my colleagues. Specifically, I want to thank the co-authors of this paper, Bill Axon, Deirdre Gamiri, and Kate Scott. And I look forward to a productive conversation after the presentation as well. All right. Okay, so this is just a brief outline of what I'm going to talk about today. Pretty basic, starting with the motivation and background, then going into the setting and the data, and then discussing the analysis results and kind of takeaways and next steps. So the motivation for this work, as Heather mentioned, it seeks to understand how parental mental disorders relate to family formation among children. And the motivation emerged from kind of the joint consideration of a number of different factors. The first is that we know that the global burden of mental disorders is high. About 1 in 5 adults experience a common mental disorder in a 12-month period. And psychiatric epidemiological studies also indicate consistent gender differences in who is more likely to develop what disorder. So women are consistently found to be more likely to have mood or anxiety disorders. So these are kind of sometimes called internalizing disorders, and men are more likely to experience substance abuse disorders such as alcohol use disorder or drug abuse. And those are often called kind of externalizing disorders. And so the next part of the motivation is this understanding that mental disorders are stressors within the family environment. There's many different ways that a mental disorder within the family can manifest in stress. The first being, role strain, so stress arising from, the need to care for a family member, maybe tensions between spouses or between parents and children, as well as the need for some members of a family to take on greater responsibilities and demands to kind of help a member of the family who's maybe suffering from a mental disorder. We also know that the family environment plays a critical role in the development of mental health problems among children. So the intergenerational transmission of mental illness is also kind of a common phenomenon. And finally, the emotional impact of a family member's mental illness on others in the family, specifically those who have caring responsibilities, is another way that mental disorders can kind of form stress or create stress within the family environment. And then finally, the other piece of the motivation is the idea that families help shape fertility behavior. I think everyone in this call is really aware of this, but that the family is a primary site of socialization for children. It is a key setting through which attitudes, beliefs, and values regarding sex, contraception, marriage, and childbearing are transmitted. Parents in particular have a strong influence on children. And so their attitudes and preferences will, influence children's own attitudes, preferences, and behaviors. And there's also evidence of positively correlated fertility behavior between parents and children, as well as among siblings. So the idea that the family is a really kind of formative part of family formation behavior of younger generations is another reason that this is something we want to investigate. So putting all of these together, these statements are widely supported by evidence from psychology, sociology, and demographic research. However, given the entanglement of mental health and family life on one end and family life and fertility on the other, there's very little theoretical and empirical work that kind of directly bridges these themes to investigate the intergenerational relationship between mental ill health within the family on one end and demographic behavior within that same family. And so this is kind of with these motivations in mind, we pose the following research question, which is we ask if there's a relationship between a daughter's exposure to her mother's major depressive disorder during the early life course and her timing or her initiation of childbearing. And following from that, we also ask specifically, does the timing of a daughter's exposure to a mental disorder in the family matter for that family formation behavior? And so in order to answer this question, we kind of try to theoretically connect mother's depression to daughter's fertility in a pretty, straightforward framework. We conceptualize this as kind of tying together two key relationships. The first being the association of maternal depression with childhood experiences and outcomes, and then also how those experiences and outcomes may influence first birth timing in turn. So our goal in this paper is really to integrate the evidence of these relationships within a life course kind of context to investigate if and how exposure to mother's depression during childhood or adolescence is associated with differentially into parenthood later on, as well as to think about a little bit about what might be contributing to that sort of relationship. So I'm going to quickly just go through some kind of literature that talks about these two different specific relationships. So the first link, as I said, is the link between maternal depression and the outcomes and experiences of children. So there's a lot of evidence in the psychology and psychiatry world about the adverse influences of maternal depression on children's early development, social adjustment, interpersonal relationships, as well as kind of school and work performance. And one specific area concerns the intergenerational transmission of mental disorders. Maternal depression has consistently been associated with child psychopathology. This includes kind of children having an increased risk of developing both internalizing and externalizing problems, as well as negatively affecting broader dimensions of social and emotional functioning during childhood and adolescence. And a few reasons as to why this might be. The experience of depression and the associated stress that comes with that can, translate negatively, for example, to the act of parenting, especially, if it precludes a mother from being consistently warm, available, responsive, or attentive to her children. There's definitely also kind of a lot of work on like the genetics of heritability, which I won't get into too much here, but it's definitely something that should be considered. Specifically, postnatal depression is a well-researched topic in this field because it coincides with children's crucial early development years. And so research has consistently found that children of mothers with severe postnatal depression are at greater risk of experiencing their own behavioral and cognitive development challenges throughout childhood. And so the influences of maternal, postpartum depression have those immediate impacts, but can also extend beyond the early years of childhood. So can also affect both physical growth, academic performance, and depressive symptoms all the way into early adulthood as well. So there are long-term implications for children of depressed parents, specifically depressed mothers. And then finally, maternal mental ill health could also contribute to children's life outcomes via attachment. So attachment theory is very much discussed mainly within the paradigms of developmental psychology, but I think it's important to bring it into the fold here because it concerns the formation of children's relationships with primary caregivers and the nature of those relationships. So secure attachment, for example, tends to develop from, responsive and sensitive caregiving between parent and child or caregiver and child. Several studies have found that infants of mothers who are suffering from depression are more likely to develop in kind of an insecure attachment style that can extend into adult relationships as well. So I think it's important to note here that a person's attachment style can have implications for psychological well-being and the nature of different interpersonal relationships kind of later on. So for example, anxious ambivalent attachment specifically is characterized in adults by poor emotional regulation and kind of more of a persistent need for validation and reassurance, as well as a fear of rejection, and has been linked to risky sexual behavior, lower relationship satisfaction, earlier sexual debut, and increased risk of anxiety and depression. So this idea of attachment that develops in childhood or in very early childhood during those really formative years or formative months between mother and child, having long-term consequences is an important thing to think about when we're talking about intergenerational effects of mental disorders on future family formation behavior, because it can extend, it has extended, it extends further on into the life course. The second relationship that we're interested in concerns the, I would say, vast amount of demographic research on fertility behavior and its links back to circumstances in childhood and adolescence. So first, we know that fertility preferences, intentions, and behavior have strong roots in the social environment of the family. Parental attitudes and preferences, family income, the size and structure of the family of origin all contribute to shaping family formation behavior like marriage and childbearing. And of course, zooming out a little bit, cultural context plays a really crucial role in that as well, in kind of shaping the family social organization of family life. Educational enrollment and attainment, as well as work experiences and careers, are also very important considerations in people's family formation attitudes and behaviors. Marriage timing, and I'll get into this a little bit when we talk about the setting, but in Nepal specifically, marriage is one of the most instrumental determinants of childbearing. So like in many settings with universal marriage, marriage can be seen as a proxy for exposure to sex or for sexual behavior, because premarital sex and pregnancies are relatively rare. So the coinciding of marriage with sexual debut means that, if we're looking at anything about first birth, we really need to carefully account for marriage behavior as well, because that will be a really important factor dictating the transition into parenthood. And then finally, fertility intentions and contraceptive use will also be really key in assessing the entrance into parenthood as well. Okay, so returning to this diagram with all of that literature in mind, my co-authors and I, we hypothesized a few potential mechanisms that could link the exposure to maternal depression to fertility behavior based on all the literature I just kind of went through. So the first would be the daughter's own mental health. So this mechanism connects the intergenerational transmission of mental health to sexual behavior, marriage, and pregnancy. We also thought about the role of daughter's education. So educational attainment, this mechanism kind of considers both the influence of maternal depression on daughter's education, as well as then the relationship between educational attainment and enrollment on marriage and fertility. And then finally, I'm going to bring back this idea of attachment. As mentioned earlier, mother's depression postpartum or even during the early childhood years, has been found to hinder the development of children's secure attachment. And the evidence that suggests that anxiously attached adults have been found to have sex earlier and even use contraceptives less consistently. This has kind of repercussions for childbearing as well. So that's kind of the theoretical framework and the motivation. There's a lot of moving pieces there, but I'm going to quickly now pivot into describing the setting and the data. And then we'll get into some results down the line too. Okay. So this is the CVFS webinar. So our work is based in Chitwan, Nepal. Chitwan is in the south central part of the country. And I'm just going to provide a little bit of context about this setting that is specifically pertinent to to this analysis. So the first is the near universal marriage and childbearing. So this means that any sort of concerns about differential selection into marriage and parenthood is relatively low, because marriage and childbearing is an experience that most people in Chitwan will eventually experience. Historically, marriages have historically been arranged by families, and this is especially true for daughters. However, this is changing in the setting. Premarital sex remains uncommon. So the sexual debut and marriage generally occur around the same time, again, especially for girls. And importantly, Chitwan has been characterized by substantial social change in the past 3 decades. This has been well documented by many researchers who've used CVFS data. So for example, that might include increased contraceptive use, more formalized education and employment opportunities, as well as the availability of more non-family leisure, consumption, and work opportunities. And finally, I just want to highlight that a recent epidemiological survey, which I will get into in the data section, found that there was a high lifetime prevalence of major depressive disorder among women, so more than 20% of the sample. So the data that I used for this analysis come from the Chitwan Valley Family Study, or the CVFS, which is a population representative longitudinal panel study comprised of all households and household members in about 150 neighborhoods. It has been up and running for more than 25 years and is made up of many different data resources. For this specific study, I combined a number of these, and I'll go through quickly which CVFS resources I used. The first is the population registry. So this is a core feature of the CVFS. The household registry includes monthly data on marriage, pregnancy, migration status, living arrangements, and I think residency as well for all household panel members. And so for this study, we used 245 months of continuous registry data, spanning from 1997 to 2016, so almost 20 years of monthly data. And so what's great about this resource for this study is that the granularity of the registry means that we can identify the exact month of both marriage and first birth, which is really helpful when we're talking about something like birth timing. Next, we use the Nepal Composite International Diagnostic Interview, so the Nepal CD. And I think this is covered in previous webinars in more depth, but just quickly to provide some context. The Nepal CD is a fully structured diagnostic tool that was designed for the epidemiological assessment of the prevalence, severity, and burden of mental disorders. The instrument is derived from the World Mental Health Survey program and was developed and rigorously tested for setting-specific use in Nepal. Between 2016 and 2018, the Nepal CD was administered to more than 10,000 CVFS members between the ages of 15 and 59. And this data set is our source for measures of maternal depression, in addition to measuring clinical criteria for diagnosis. The Nepal CD retrospectively assesses the timing of disorder onset using a life history calendar to enhance recall and minimize bias. Before I move on, I want to emphasize that the CD measures mental disorders. So this kind of connotes a higher level of impairment and severity than, for example, typical symptom or mood screeners that are commonly used in population mental health research. So this is a really crucial advantage of this data set that actually measures disorders rather than just the presence of symptoms. The 2008 CVFS individual interview provide our control measures of parents' education and marital experiences. And the 2006 CVFS agricultural and consumption survey provides our measures on household economic resources, land use, consumption, and house quality. And then finally, we use the CVFS household relationship grid to create family units, so that the grid kind of maps family relationships. So it allows us to match daughters to parents, which is a core part of this work. Our sample is a multi-generational sample. It consists of mother, father, daughter triads, which match daughters at risk of giving birth to data on their parents. So this includes parental data on mental disorder history, as well as information on parental background, experiences, and resources. All daughters included in the analysis were at risk of giving birth at some point between 1996 and 2016. So during the years for which we have month level registry data. And our hazard of first birth, we start that at age 10. And then finally, our sample was restricted to daughters for whom both parents completed the diagnostic Nepal CV survey. So quickly, just to get into how the measures were operationalized, the outcome is first birth timing, and the months of first birth is taken from the household registry, as I mentioned before. Maternal depression was measured using the CD interview, and we use measures of lifetime prevalence and assess the age of onset retrospectively. We are able to use this age of disorder onset to create a time varying variable of mother's depression that we could align with the daughter's age. So this was, essential to understand, when in the daughter's life course the mother developed depression. And in that vein, we also, in order to investigate, any potential role of disorder onset timing, I created 3 additional dummy variables marking when in the life course daughters were exposed to their mother's depression. So the 3 variables are before birth, between ages 0 and 10, and 11 or older. And then these are kind of the other covariates. I won't get into too much detail, but we also accounted for parental marital experiences, education, household assets, and resources, as well as ethnicity and age. Okay. So into the analytical strategy. So we use discrete time event history models to estimate the time to first birth. And the analytic data set was operationalized at the person month level. So we use person month hazard files. As mentioned previously, marriage and fertility are closely related in Chitwan. And so we wanted to account for that in our modeling strategy. So we use 2 hazard approaches in order to disentangle the mediating role that marriage might have in the relationship between depression and fertility. So the first hazard starts from age 10 and does not control for marriage. So it looks at the relationship independent of the timing of marriage. But then we also used a second hazard strategy, which is a hazard beginning in the month of marriage. So in this hazard, we restrict the analytical sample to married women only. And that allows us to explore heterogeneity in first birth timing independent of the effect of marriage. And so with these 2 hazards together, we kind of get a more complete picture of where marriage fits in the story. And so I'm going to briefly show a visual representation of the modeling strategy, kind of laid out in a life course, from a life course perspective. For me, I find that diagramming out the question this way, I'm able to visualize various moving parts, because I think this question has a lot of components and it can be complicated. So this helps me kind of fit it together into a relatively simple schema. So here is a very basic life course timeline from birth to the transition to parenthood. And, we are interested in daughter's exposure to maternal depression overall, so anytime, but also in differentiating the potential influence of when exactly that maternal depression developed, and to see if that has any kind of effect on what relationships we see. So that's kind of aligned here with the life course. So before birth, age 0 to 10 and age 11 plus. And then these are the 2 hazard strategies I talked about in the previous slide, these yellow lines. In the first one, which is the bottom one, the daughters become at risk for first birth at age 10. And in the second one, they become at risk at the point of marriage. So we estimated the hazard of first birth for both of these approaches. Now to get into what we found. Okay, so the analytic sample consists of 1,306 matched mother, father, daughter triads. So that's 1,300 mothers, 1,300 fathers, 1,300 daughters. Of these daughters, about a third got married and 22% had their first birth during their analysis period. And a quarter of mothers in the sample had an experience of major depressive disorder before the daughter got married. So this is the onset age distribution of when in the daughter's life course the mother's depression onset occurred. As you can see, most mothers, about 80%, developed MDD or major depressive disorder, before their daughter turned 11. Just a little bit of more of descriptives. The mean age at marriage of the daughters in the analysis was 20.9 years, and the mean age of first birth was 22.4 years. And this is, among daughters who got married in the kind of analysis period that we had data on, those who got married, as well as the ones who became parents. Okay, so I'm going to show you the results first from the first hazard model, which shows odds ratio estimates of the hazard of first birth from age 10. And so these results are for the first hazard strategy, like I said, and they're controlled for all of the covariates mentioned earlier. So in there are 4 models here. Model 1 shows the effect of overall maternal depression, which we can see we don't really see an effect here. The odds ratio is essentially 1. So, overall maternal depression, we don't really see any association with daughters' fertility timing. But then we kind of, models 2 through 4 look at the association of differential disorder onset. So breaking down the mother's depression at different times in the daughter's life. And so I want to draw your attention to model 3, which I think jumps out the most. This model highlights that daughter's exposure to mother's depression in her early childhood, so between ages of 0 and 10, was quite strongly associated with first birth. And so here we see that the odds are more than 2.5 times higher each month. And this provides really important context for the overall odds ratio of 0.99 in the first model, because we can see that it can be broken down in a clear speeding up of the rate of first birth during this early childhood exposure period, but it's offset kind of by estimates in the opposite direction for the other disorder onset periods. And so, this adds a really important context or dimensionality to what is actually, underpinning the odds ratio in model 1, the odds ratio of 0.99. And so, this was really interesting to us. And then we went to the next hazard model, which looks at just married women. Does this relationship exist even after we control for marriage timing? And that's what we look at next. So again, this table is in the exact same format, and it shows the result from the hazard models starting at marriage. And there's a lot going on, but I want to kind of point out 2 main things to discuss from these models. The first being this odds ratio in model 3. We find here that there's still a persistence of an association between daughter's exposure to maternal depression during her early childhood and an accelerated hazard of first birth compared to all other daughters in the sample, as well as controlling for mother's lifetime experiences of mother's lifetime depression. And so because this hazard begins at marriage and models first birth prospectively, this relationship that we see cannot be explained kind of by marriage, by the timing of marriage alone. Interestingly, though, one thing I want to note, this is not written on the slides, but the second key point concerns the difference between the 2 hazard approaches. So the odds ratio estimates of multiple covariates in the first model, measuring the hazard of first birth from age 10, that did have a significant association. So this includes mother's post-secondary education and household assets. Both of these were strong predictors of first birth timing, but the strength of that association disappears in the second model. So marriage kind of accounts fully for those covariates influence on first birth timing in the first model. And so while the relationship of those variables with first birth can be entirely explained by accounting for marriage behavior, the same is not true for this measure of maternal depression timing. which is just interesting that, of all the covariates in both models, this one is the one that remains significant in this one, in the shorter hazard, or the hazard from marriage model. Okay, so key takeaways from the results is that mothers' overall lifetime depression was not associated with differential fertility behavior among daughters. However, when we broke down the age of daughters' exposure to maternal depression, we see that the story is a little bit more complex. Daughters' exposure to mother's depression in early childhood was associated with faster first birth, and then this account, even after accounting for marriage timing, we still see that relationship. Okay, so what does this all mean? I'm going to try to contextualize a bit more what we're seeing and how to interpret what we're seeing. So this is the association that we're aiming to understand between exposure to mother's depression and first birth timing. And like I said, we found that the exposure during early childhood significantly speeds daughters' entry into parenthood later in the life course. But we also know that marriage is a key proximate determinant of fertility, especially in this setting. So we needed to ask whether the association we found could be explained either entirely or in part by marriage behavior. And our answer is that it somewhat can. So the odds ratio does go down from 2.7 to about 1.8. So even after controlling for marriage, the relationship does persist, although it is a little less strong. So what we're seeing seems to be, we are seeing a speeding up of marriage that is associated with the exposure to mother's depression early in childhood. But we're also seeing faster first birth rates within marriage. So after marriage occurs, among daughters exposed to maternal depression in early childhood. So, the relationship of the 2.69 is maybe partially explained by marriage timing, but not entirely. And there's actually something else going on. And notably, we find that it doesn't just matter if a daughter is exposed to maternal depression at all, but it really matters when in the life course that exposure occurs. And in our findings, early childhood seems to be a specifically crucial time period. And this really plays into the idea of the life course principle of linked lives between parent and child. So this understanding that the timing or sequencing of experiences matters when considering interpersonal relationships and how they may influence one another. And as to why we see this relationship, the relationship between exposure to mother's depression early in childhood and first birth, as I touched on earlier, this finding is pretty consistent with evidence from psychology, which finds that children's exposure to maternal depression, especially in the early development years, has far-reaching implications for including poor mental health, academic performance, social adjustment, relationship quality. And specifically, I mentioned a little bit earlier about attachment, the idea that impairments due to depressive disorder can adversely affect the caregiver-child bond, as well as kind of the parenting quality and attentiveness and the resources that parents can provide children. So the kind of risk of an insecure attachment style being developing because of those early years and the parenting experiences of those early years having long-term effects is also something that we've been thinking about. And so we haven't been able to really test these specific hypotheses here, but in the future, I think we hope to explore these mechanisms a little bit more. But for now, we do believe that the consideration of parental mental ill health is an important yet understudied factor in family demography. We know it's very widely studied in psychology and psychiatry and development, but it also might have implications for other aspects of social life, including family formation, marriage, fertility, sex, and childbearing. Finally, I just want to quickly go through kind of what I see as the key strengths of the study, as well as some limitations. So I think one of the biggest strengths is the availability of the mental disorder measures from the CVFS Nepal CD instrument. So these measures, like I said, were designed and targeted specifically for this setting, and they were collected through diagnostic interviews and therefore provide more comprehensive insights into mental health than do more kind of straightforward symptom screeners. And secondly, we have month-level outcome data on first birth. And this is, I think, as I was working through this project, became even clearer of how important this is. So the registry data from the CVFS on pregnancies and births every month provide sufficient precision for us to kind of operationalize a post-marital hazard of first birth. And what this means is that because the average marriage to birth interval in our sample, it's around 2 years or a little bit less than 2 years. So having month level data is essential, basically, to observe any sort of heterogeneity or variation in fertility behavior after a marriage occurs. So that's a huge asset to this work. And finally, the longitudinal design of the CVFS really lets us appreciate kind of this life course framing in which childhood experiences are crucial for understanding future trajectories, especially when we're aiming to understand how one person's mental disorder may shape the experiences of those around them. The household panel study is the perfect design for that. And so using features of the CVFS, we were able to approximate the timing and sequencing of a child's exposure to a mother's depression because we had this longitudinal multi-year data set for all family members. Some limitations, right now, like we don't have complete data on daughters' mental health because not all daughters in this analysis were able to be interviewed by the CDE and by the Nepal CD instrument themselves because of age constraints. And also one thing that is, I think, a challenge for mental health research all the time is the use of retrospective assessment of disorder onset. The Nepal CD team did use life history calendars to kind of try to minimize that bias, but of course that's always going to be a concern when you're using retrospective assessment of disorders. Finally, like this is still a work in progress. So we have a few things that we want to consider moving forward, including maybe more information on mothers' childbearing experiences, daughters' educational enrollment, cohabitation, as well as bringing in other CD disorders, including father's disorders and anxiety and alcohol use disorders as well. And also to get a little bit more into quantifying, what exactly that mediating role of marriage timing is. And then another thing that we were thinking about is kind of the pregnancy versus the birth hazard and kind of what that differentiation might tell us. So definitely a lot that I'm still hoping to do and develop, but I hope that we have a good discussion, and I definitely would love some feedback and thoughts of how to move forward. And yes, so thank you everyone for being here. It's great to share this with you.
Thanks, Emma. Thank you for that provocative presentation. And I'm going to give you a minute to not only take a break from very nice presentation, but to read Michaela's comment in the chat, which I actually, I think it raises a good point. And Michaela, thank you for saying that you're unfamiliar with the methods, and yet your point seems quite reasonable prima facie. That is, in a hazard where we're looking from age 10 onward, why look at later onset? The truth is that the later onset only counts if it happens before the kid's marriage. But Emma, I suspect that if you started that hazard at age 15 instead of age 10, you would see no difference at all in any parameter you estimate, which might make it worth doing to absolve yourself of this potential concern. Michaela, think about that for a second while Emma responds, and let's see if you have another, if we just started the hazard at age 15, would you find that satisfying? Yeah. Go ahead, Emma.
Yeah, no, I'm happy to respond. Thanks, Michaela, for your question. So I think one reason that this is not, I'm personally not as concerned, is that it's a time varying covariate. So until the mother develops the depression, so let's say the daughter is 12 or 13 when that onset occurs, it's going to kind of be coded in the hazard file as 0, right? The mother doesn't develop depression. And until the onset occurs is when it kind of switches on. So it does account for the timing, if that makes sense, because we're using every month as a kind of entry in the hazard file. So even if the mother's onset is later, it's kind of aligned with the daughter's life. So her at-risk time will start at age 10. But for example, if the onset of depressions is at age 14, it won't kind of be included as a predictor until that point.
Okay,
that-
that makes sense. Yeah.
Does that make
definitely.
sense?
Yeah. Yeah, I'm just not super familiar with the method.
No,
so
no, of
thank you. That
course.
makes a lot of sense.
Thank you.
Yeah, thank you for that question. And happy to come back and talk about the methods more, but I saw Coulter's hand followed by Sarah's hand.
So first, Emma, you've done a lot of work. Good job. Congratulations on that. I kind of have three different things. One is sorry, I'm kind of losing my voice. I have a little bit of a cold, not COVID. So one thing is related to your like next steps. Of course, like I have all sorts of ideas. If you ever want to think about genetic nurturance, I'm happy to talk about it. But the bigger point on some of those things is, Bill's probably already told you that, but I was like, oh, that looks like a whole career, not even just a dissertation. That's a lot. It's a lot.
Yeah.
So please keep, I remember being enthusiastic about doing all these different things. That's a lot. That's a lot. You're already doing a lot. Hopefully you can do all of those things. So there's two. The one thing that I'll say is that you did a lot of great work. I spent a lot more time with developmental psychologists than I ever thought I would. There's a huge literature as you've described. And depending on which journal you end up going to with this, you might have to beef that up a lot more or cut it way back. Right now you're kind of in this intermediate place. But here's the one thing that has kind of set off alarms a little bit with me, was looking at the different statistics, was just how big the standard errors were on a lot of those estimates and how much they were moving back and forth. Just made me wonder, is this a sample size issue? There's like some extra collinearity things. You've done so many great tests. Yeah. But like as a reviewer, if I were to see that, I'd like alarm bells would go off that like, wait, this thing is, an odds ratio of 2.6 is huge. Yeah. And yet, similar coefficients, even in psychology with much smaller samples, are much, much lower than that and don't change it. So it's like, okay, is there a collinearity problem going on here? Or is it like the fact that we have such fine-grained outcome data paired with dividing the samples up into certain ways that somehow we're getting some sort of strange sample size reduction that we're not, does that make sense?
Yeah,
And
absolutely.
you probably looked at all of this, but that's what the reviewer in me was like, noticing.
Great. Thank you so much. I'm going to make a note of that.
Thanks, Coulter. I saw Sarah's hand next, and Emily, I saw your hand briefly. I'm gonna ask you about it after Sarah finishes.
So I also was wearing, I wore two hats for this. I have my reviewer hat and then my CVFS user hat, which has some very technical questions that I want to ask, but I want to ask the reviewer hat question first, which is, it looks to me like in your models, you have a variable for whether the mother ever had the MDD and the timing of it. And so kind of picking up where Coulter left off, I'm wondering if why you control that way. Why don't you have models that show me that have all of those time periods as separate variables? Before birth, yes or no, birth to age 10, yes or no, and then the time varying measure.
Yeah.
Yeah.
Yes, that's a great question. The answer is that we do have those, but they're just not in this presentation. I think the idea was when we were looking at the timing breakdown that we were going to do kind of 5 models, one being overall, one being the overall and the dummy variables, so that we could kind of compare the dummy variable to, all, depression ever and everyone else. I think that was the idea of having the models 2 through 4. And then we
definitely who's in the comparison group is definitely what's going on.
That was exactly that kind of, we wanted to make sure the comparison group was not just anyone who didn't have the onset during those years, but also including the people who had any onset time. And then we also did a final model, which I didn't show today, of what you just said, of each of the timings individually together.
And could I Emma, that's a very accurate and reasonable response.
Yeah.
I guess I wanted to give Sarah one other level of background, which is I want to confess, I did not think of this. This was really our colleague collaborator named Kate Scott, who I don't think most of you know. She's a clinical psychologist who works on the World Mental Health Consortium and is one of the lead analysts of data from there. She's very highly published in psychiatric journals. And she pushed very hard for this approach based on, and Coulter's, tease about developmental psych literature reminded me of this issue as well, based on her view of what is already known and established in the psychiatric literature about timing of maternal mental disorders and its impact on kids. And I'm sort of like, okay, but let's imagine sociologists, demographers don't know any of this. Now what, And so I'm very interested in your reaction to that, Sarah, from a perspective. Okay, you said your reviewer hat, and it is going to affect what kind of journals we go to. But this story is one of a length and level of detail that is not in the comfort zone for the psychiatric epi literature. I'll say this is much more, currently constructed for a social demographer kind of literature.
So I love the timing approach. Like I mean, that I love. What I don't love is it feels like you have this variable in the model twice. It feels like you're over controlling.
I know.
And so like, I have to think really hard about what this comparison is. I don't like to think that hard, like just being totally honest, like, I can't interpret that overall coefficient anymore. It's a little bit like having an interaction term in there. And I don't want to see a table with interaction terms. I want to see some.
No, it parses the comparison group. So I think you're correct. And I'm wondering, Emma, the reason I wanted to push her for more on this is because I want to go back to Kate Scott and push her on this, because we have this issue in all of our work with her on these kind of topics where there is this literature on women get depression, but postpartum depression is different because postpartum depression interacts with this very crucial period in the young child's life, and therefore generates a different type of long-term consequence for the child. Okay, theoretically, I follow along. What does that imply about what the model should have in it? And Sarah, if you don't mind saying one more time, just so Emma and I can be clear when we communicate with Kate, like if I told you, hey, this period of 0 to 10, postpartum, child is young, is a different thing than other time periods, what is the sort of knee-jerk first place you as a leading sociological demographer might have gone with operationalizing that into a dummy or a covariate or something?
So I definitely would have those variables. So the table right now, I'm like picturing it, right? It's got a variable forever across the top, and then each separate model has the different time ones. I would want a model that has those 3 separate timing ones in one model.
Yeah. Okay.
Because it's not right. You're just talking about onset. You don't know if this has come on and off, right?
Correct.
Right.
So
correct.
it's just, these are mutually exhaustive categories. So it's like race, like you're one or, well, it's not, it's terrible. That's like the worst example I could have picked, right? It's like education, like you wouldn't put years of education or you wouldn't put ever went to school and then like what year you stopped going to school in the model. Like that would be weird. I mean, maybe technically you could, and it's telling you something, but you wouldn't do that, right? You would just have a dummy variable for what year did you stop going to school. So to me, that would feel like a more intuitive comparison. And then I can say like, oh, you got this at this time period. Although then the comparison is never.
And actually,
and that's the issue, right? That's totally the issue, is that first one is sorting out the ever versus never, so that the other ones are just comparison group. It's this timing versus the other 2 timings.
Yeah, we did, Sarah, we did what you said is a model that we did run as well, like not having the overall, but just having the 3 together. But I think then the concern was like, what are we comparing? And essentially those three together will add up to the first one, right? Because it's every disorder onset. And I think what's challenging is it's hard to talk about, first of all, but also to understand how do we, so that's why we kind of did it in multiple different ways.
Okay, maybe you just in your table, you need the
clearer.
comparison listed for
Okay.
each one, right?
Yeah.
So
What
like
the omit, what the
what the omitted
comparison
category
group for
is
that
to that.
coefficient is, that is, and that's an interesting point. I mean, we could on the labels for the rows put, you know, it's onset 0 to birth to age 10 relative to onset before birth or after
Yeah.
10. It's not relative to no onset. It's not
It's not-
relative to no onset. It's relative to there was an onset. It was just a different time.
Right, right.
Hmm.
So it's interesting. So I mean, I've actually have written some of these papers with like using fragile families where we try to get timings things, and that's where we have like multiple measures of it. I will say that one of the things that, and this is why I mentioned the developmental science thing, is actually 0 to 10. Like for a developmental scientist, that's too much. Like
It
you
is
would-
colder, but it's interesting.
Yeah.
You have this interesting problem the other direction in
Right.
the fall, which is, okay, what is 7, 8, 9 mean? Whereas back to Michaela's point, one interesting thing about an onset that's at child age 15, 16, 17, 18, that now becomes concurrent
right.
with the child's experience of marriage and maybe those early years of marriage or something like that, which is into like, okay, mom has a problem now while I want to have a kid or something. Do I have a kid or not? You know, it's a little bit different kind of mom-kid interaction than mom had a problem when I was a little kid.
No, and I understand that. I mean, this goes counter to my concern about sample sizes, but and concerns like that. But I started to go down this path of like a developmental scientist would be like, yeah, 0 to 5 is pretty much that's where, and then you'd have a middle childhood sort of thing.
Yeah.
And they get 0 to 10. But again, if this is targeted toward a sociology journal, then I think you have a slightly different, or the demographic journal, then I think you have a different story.
Coulter, I want to give Emily a chance, then come back and ask Sarah her CVFS data user.
Yeah.
Sure. My question, I mean, I definitely agree with Coulter's comment about under 5 and 5 to 10.
Mhm.
But what I wanted to ask about was actually kind of related to Sarah's question and the definition or how you're thinking about onset. So are you essentially saying that as soon as MDD is onset, then that person is exposed for the duration of their childhood? Or is there more nuance and time varying?
Yeah, so thanks for that question. Right now we don't have data kind of on like how long the depressive episode lasted or whether it's recurring. So yeah, right as of now, we only have the kind of the onset age and then moving forward. Yeah, so that's definitely something that
turns out empirically that's a tough one.
Yeah.
I don't even know if it's possible.
Yeah.
So then I think if it's not possible, then your approach is totally reasonable.
Well, Emma correctly comes back to these limitations of retrospective reporting. In a sense, that's it, right? If you're lifetime retrospective reporting a 50-year-old person to tell you, you know, your symptoms across lifetime, we did a lot of work to get accurate at when they began. Getting the nuance of when they end, when they start up again, when they end, when they start up again, when they end, that's a tall chore. Panel data would be much more successful. So the leading thing is this New Zealand study that has annual interviews of everybody. And guess what? If you interview everybody every year you could do much better with onset and cessation and onset and cessation.
Thanks. Yeah, no, that's clarifying. You might want to say something about it in limitations, but I think the approach is totally reasonable. No, I assumed the answer was going to be it's not possible to reliably collect all of that information over time. So I think with what you have, it's a very reasonable approach. And I do like how you parsed it out. And I think you did a really nice job explaining the differences in those effects and how they go towards the null until you parse them out.
Thank you.
Sarah, if you want to go back to your data question.
Yeah, also, I think I was so excited to ask my question. I forgot to say that I thought that was an excellent presentation. I think
you.
you
Yeah.
did, like, the PowerPoint looked great. You did a really great job delivering it.
Thank you.
All have graduate students like you. That was wonderful.
Careful, Sarah, this is being recorded.
Okay, I have a couple technical questions, which and then I'm going to end with a more theoretical one. One is, I'm wondering how you made this mother, father, child link, like which files did you use? And that maybe I want to talk with you about that because we're doing some linking around the same time period.
Happy to, yeah.
And then what about, also, I'm not sure these data are ready yet, but looking at the marital arrangement of those kids. I mean, you talk about marital arrangement, and I think it's interesting to think about mothers' mental health as influencing how those dynamics and conversations unfold. Maybe that's just a separate paper looking at maternal mental health on kids' marriage formation. But yeah, I'm wondering if that would help understand that, tell you more about that mechanism, if those data are available. And then, am I correct in understanding that in the hazard that starts at age 10, you don't even have a time varying control for marriage? It's just the hazard, assuming that because the interval is generally 2 years, it doesn't really matter.
Oh,
Yeah.
no, they're married. And then it's person months till they have a baby.
No. That's
she's
the
talking
one
about
that
the first
starts
hazard.
marriage.
Oh, the first one.
Yeah, so we did it multiple ways. The model
Coulter was worried about an odds ratio of 2.69. Emma, tell them what the odds ratio on marriage is when you put it into that hazard.
Yeah, so we did do it where we also added a time varying covariate for marriage. It was like, 1,000 or something.
Yeah.
And so that's why we, I think presenting it that way might have been a little shocking to people. So that's why we kind of did it in the two ways. So yeah, in the first one right now, we don't account for that one time varying covariate. But then
I did like it, right? I liked it from where Sarah was going.
To see.
Yeah. It's like you do, okay, we'll ignore marriage. We get all these coefficients. We'll add that covariate in. Coulter goes to 1,000. And all the other coefficients disappear, except for this one for maternal depression between ages 1 and 10, which turns out to come up with an odds ratio. What was that again? Oh yeah, 1.82.
Yeah.
Exactly the same as if you run the hazard.
Yeah, exactly. Yeah. So we got the same finding, like basically same results doing it that way. But I think it just made more sense from a kind of a presentation point.
It was less scary.
Less scary for me as well. About your technical question. So the linkage was done using the household relationship, the different relationship grids. Full disclosure, an analyst kind of did that main work before I came to Michigan. But I have gone through the code, and then there was an issue where we updated some of our relationship grids. I think it was like a year ago. But I have access to that, code. I'm happy to talk to you about it anytime.
Is this the T4 grid that you were using then?
So
only that.
No, we used all of them basically to.
Okay, then I am going to send you an email to follow up because we're having a lot of problems with the T3 grid. And so
okay.
Okay.
So I think you better copy Dirk on this. So Emma's quite correct. We discovered errors in the data entry. Relationship grid data was paper and pencil in the IDs, and Dirga's team put a lot of effort into correcting that. And I just want to make sure he's in the loop so that you're not going down a rabbit hole that he's already been down and figured out. Yeah, we're not doing it twice.
Yeah. Okay.
Yeah, my understanding is that we started with T3 and then used the others as supplementally, but I have to verify which order that went in when our analyst did it. Yeah.
Okay, thank you.
Yeah, absolutely. And then the question about arranged marriage, I think this is something that Dirk and I have maybe talked about briefly, but we don't, I think, have much information about the arranged marriage of these daughters. We have information on the parents, right? But is there
Oh,
some?
wait, we have it on the daughters. They just
we do.
haven't used it before.
Okay.
So I've been needling him. The part of the conversation that Emma doesn't understand is where I'm like obnoxiously needling Dirga in the background with these gentle comments about, hey, you really need to do this because this would make a really good paper. Emma, I tried not to be too explicit about it to avoid it getting any more obnoxious than it already was. But yeah, I think this would be a great paper. We have another paper on hazard of marriage timing, which reveals a lot of interesting stuff. But I agree that this issue of as we've studied it before, Dirga's paper on marital arrangement per se is a pretty interesting additional piece of the puzzle for sure.
Yeah, I think particularly with this maternal mental health, I mean, who knows what you can say, but what the implications for just really understanding household dynamics and family relationships, I think it's just really interesting.
It is super interesting. And it turns out if your spouse hits you, that's depressing no matter what.
Yeah.
But it turns out that having your parents pick exactly who you're going to marry is depressing to both men and women. It just happens to women many, many, many times more often than it happens to men in Nepal.
Yeah.
Pretty interesting, I agree.
Okay, it's after 3.
Okay.
I wasn't even going to say that. Thank you, Heather. Thank you, everyone, for all your contributions to making the seminar a success. Emma, that was a great way to end this year's talks. We really appreciate that.
Thank you.
Heather, all of us appreciate all you've done to keep this organized and going. Thank you so much.
Yeah, it's been really nice seeing everybody every few weeks. So thanks.
Yeah, I agree. That's great. Thank you.
Bye.